There's so much to see here. So much work has already been done. Building momentum to create more of this. Quality of life. In a world with less communicable diseases, more people have the chance to build better, healthier, safer lives. But the momentum cannot stop here. The COVID-19 pandemic has shown us that as long as communicable diseases continue to spread, the quality of our lives is at stake. We are all at risk until everyone is safe. That's why PAHO's Elimination Initiative has set its sights on eliminating more than 30 communicable diseases and related conditions by 2030. To achieve this, we must ensure everyone in the Americas has access to vaccinations, quality health care that includes timely diagnosis and treatment, as well as water, sanitation, and hygiene facilities. This is not a dream, it's a right and everyone's responsibility. We should all have an equal opportunity to enjoy healthy, impactful lives. There's so much more to see here. So let's work together for a disease-free future for all. There's so much to see here. So much work has already been done. Building momentum to create more of this. Quality of life. In a world with less communicable diseases, more people have the chance to build better, healthier, safer lives.
Good afternoon. Good afternoon. Good afternoon. Yes. Buenas tardes. Good afternoon. Buenas tardes. Good afternoon. I'm honored to welcome you to this briefing session on the Elimination Initiative, implementing innovations and best practices for communicable diseases elimination in the Americas. This session is part of the 61st PAHO Directing Council and the 76th session of the WHO Regional Committee for the Americas, taking place this week in Washington, D.C. We offer simultaneous interpretation services in English, Spanish, French, and Portuguese, and the session is being streamed live in PAHO YouTube channel. Approved by PAHO member states in 2019 and relaunched last year during the 60th PAHO Directing Council, the Elimination Initiative is an ambitious commitment to eliminate over 30 communicable diseases and related conditions by 2030. This initiative presents a pivotal opportunity for countries and partners in the Americas to strengthen national health systems, drive innovation, and enhance disease control and surveillance. Key pillars for delivering integrated health services to the most affected and vulnerable communities. In today's event, we will learn about the use of innovative technologies, but also approaches to use these technologies from 4 countries in the Americas for eliminating diseases such as hepatitis C, tuberculosis, HIV/AIDS, and lymphatic filariasis. We will also hear from partners and civil society organizations about their perspectives on the Elimination Initiative. The Elimination Initiative is everybody's business at PAHO. Apetitivo por innovar, compromiso con equidad, was telling us the director a few moments ago in his report to the Directing Council. I'm Judith Riu San Juan. I'm the director of the Department of Innovation, Access to Medicines and Health Technologies since 10 months at PAHO. And I can assure you that fulfilling and ensuring the member states can fulfill the goals of the Elimination Initiative is a top priority for me as new director. To succeed, we must learn and innovate in our ways of serving the region. We must foster multi-sectorial collaboration, active community engagement, and a focus on equity, ensuring that interventions, including technologies, needed for disease prevention, diagnosis, treatment, and monitoring are scaled up and accessible to those who need them. PAHO approach to increasing innovation and access to health technologies unfolds a comprehensive strategy that aims at addressing the product life cycle from innovation and production to strengthening regulatory frameworks and support evidence-driven decision-making for the selection and access to the specific technologies. We have reviewed the products included in the portfolio of the regional revolving funds to ensure technologies that are needed for the Elimination Initiative are available to member states. A key focus to PAHO is to generate ecosystems that not only promote regional production, as we heard today, but also regional innovation to ensure the public health needs of the region, including those of the Elimination Initiative, are prioritized. We are also reviewing the R&D and access needs of the Elimination Initiative and strengthening and focusing our technical cooperation to member states to ensure we deliver. We have the tools to deliver in an affordable, available, and adequate way. Because what's our common goal? Our common goal is for health systems and population to have access and to achieve impact. Thank you for being here today. Again, it's an honor to welcome you in this important side event. Now I'm pleased to introduce Dr. Jarbas Barbosa, PAHO's director, for the opening remarks. Welcome, Dr. Jarbas. The floor is yours.
Thank you, Judith. Good afternoon. I think that now I'll be very brief because I think that the main purpose here is to listen from you, is to have the countries that accept to share the experiences, to tell us how they are doing, how they are progressing, also to listen from some partners that we have here in this room, how they can partner with PAHO to advance this agenda. We have interpretation, translation, so I think that everybody can speak in the language that feels more comfortable. As I mentioned, PAHO, the Americas, we are a global leader in the elimination of the diseases. In the many last decades, we have made some very important progresses toward the elimination of diseases. But now, we have a new opportunity. We have many diseases that we have the strategies, we have the tools, so we can advance the elimination of these diseases. I think that this is really important. As I like to say, it's not only a public health approach. It is also a moral and ethical obligation. We can make all the efforts that we are able. We need to redouble our efforts in order to guarantee that the most vulnerable people in our region can have access to the tools, strategies, medicines, laboratory tests, vaccines that can reduce the burden and eliminate this disease. Let me now switch to Spanish to finalize. Solo para concluir, né, como também mencionei, esto es una contribución concreta del sector salud para la equidad. Porque las personas que tienen esas enfermedades que estamos mencionando son las personas más vulnerables. Son las familias pobres que viven en los más pobres barrios de las grandes ciudades. Son los pueblos indígenas, son las personas que viven en áreas aisladas, son personas de descendencia africana en nuestra región. Y cuando se enferman, se quedan todavía más pobres, porque pierden la capacidad de traer renta para su familia. Entonces, esa es una contribución concreta para la equidad de la salud en la región, y creo que va a ser una oportunidad muy importante compartir, verificar como estamos avançando, quais são os desafios, quais são os retos, e seguir como na região trabalhando de maneira conjunta para a eliminação dessas enfermidades. Muitas graças. And now I want to call our Assistant Director, Dr. Rhonda Philip Thomas. No, Judith, please. You are the moderator.
Thank you, Dr. Barbosa. Thank you for reminding us that we are not starting from zero, that we have a long history and elimination efforts and successes in this region. Thank you again for also putting moral and ethical obligations at the center of the work that we do every day. And now, yes, I'm pleased to introduce Dr. Rhonda Shirley Thomas, PAHO's Assistant Director. She's going to talk about the efforts to accelerate disease elimination in the Americas. Welcome, Doctor.
Thank you, Dr. Ruiz, and I want to recognize Dr. Barbosa, our director, distinguished ministers, ambassadors, colleagues. Good afternoon. I'm honored to present on the regional overview of the progress of the Elimination Initiative in the region of the Americas. Next slide. In our region, several diseases are within our reach for elimination, and the time to act is now, ladies and gentlemen. With strengthened efforts over the next years, we can achieve remarkable milestones. As the slide illustrates, yaws can be eliminated in 48 countries, and human rabies transmitted by dogs in 19 countries. The elimination of the mother-to-child transmission of HIV and syphilis is within reach for 8 countries, while foot and mouth disease and schistosomiasis could be eradicated in 7 countries each. Malaria is on the verge of elimination in 8 countries, and leprosy in 7 countries. We can put an end to open defecation in 20 countries, as well as to the use of polluting household fuels in 13 countries. By accelerating our efforts to eliminate these diseases, we can save lives and serve as powerful motivators to engage governments, health workers, and communities in the shared mission to eliminate many more diseases. By accelerating our efforts, such as including developing plans and launching national and subnational roadmaps and strategies, we can eliminate these diseases. Next slide, please. Since the launch of the Elimination Initiative at PAHO's Directing Council in September 2023, national synergistic efforts have gained significant momentum in our region. Countries in our region have made commendable progress in launching and developing national and subnational roadmaps, plans, and strategies. For instance, Brazil, Colombia, and El Salvador have launched and are implementing strategies for multi-disease elimination with a strong emphasis on primary health care and addressing the social determinants of health. These national plans serve as a robust framework for achieving disease elimination on multiple fronts. Countries like Chile, Guyana, and Honduras are making strides in developing comprehensive roadmaps for multi-disease elimination. Nicaragua, Guatemala, and Panama are also engaging in discussions and planning efforts to identify and incorporate key components into their national strategies. At the subnational level, Bolivia has taken a proactive approach by documenting access barriers to integrated health services. This vital work not only highlights the challenges faced at the local level, but also provides valuable insights that will shape and refine future elimination strategies. These national and subnational efforts represent a great starting point, laying the foundation for a concerted push towards elimination of multiple diseases across the Americas. The progress so far demonstrates the commitment of our member states to this goal and reinforces the importance of collaboration both within countries and across the region to achieve our shared objectives. Ladies and gentlemen, national and subnational roadmaps, plans, and strategies, while critical for the disease elimination, are not enough. We also need innovative solutions. Next slide, please. This slide details a few examples of access to innovative solutions that already exist that can help countries accelerate the elimination of diseases. For example, in the area of diagnostics, 11 out of 35 countries now use dual HIV syphilis tests. 7 of 49 countries use AI-powered portable X-rays for TB, and 14 of 49 countries have implemented HPV testing. In the area of surveillance, integrated serosurveillance is advancing in 3 countries, Brazil, Mexico, and Paraguay. And geostatistical methods for neglected infectious diseases are advancing in 3 countries, Brazil, Guyana, and Nicaragua. To improve access to treatments and vaccines, 34 out of 51 countries provide Hep B birth doses, and 48 of 51 countries and territories are incorporating HPV vaccines in their national immunization programs. Additionally, 27 of 49 countries use PrEP, serving 167,000 people in 2023. In closing, I would like to emphasize that to accelerate disease elimination in the Americas, we must turn our plans into action. We need to both mobilize resources and forge strong partnerships. Collaborating with countries, NGOs, and the private sector allows us to share good practices and pool resources. We also need to use the innovative solutions just outlined that many of our countries are already using. Ladies and gentlemen, as Assistant Director with the responsibility for all the technical areas within PAHO, I could speak for the entire afternoon on disease elimination, which is a priority for the organization. But today, we're here to listen to our member states. And you can see from my final slide, we have 2 portals where you can, next slide please, where you can access information on the Disease Elimination Initiative. We also have our staff who are here. I urge members of the delegations to engage with the members of the CDE staff to learn more about Elimination Initiative, and we also have a booth in the hall where you can get more information. So thank you for your kind attention.
Thank you, Dr. Silly Thomas, for really giving us a very excellent overview of the concrete efforts of member states and partners in the region on these efforts to disease elimination. We have a packed agenda, very ambitious agenda. We're going to now start the first panel, and I would like to start by introducing our esteemed moderator, Dr. Alison Krentel, to please join me. The session today is going to basically be divided in 2 panels. The first panel, we're going to listen from member states, and the second panel, we're going to listen from partners and civil society. I would like to invite the esteemed representative from member states on panel 1 to please join me in the chairs in front of you, as well as our esteemed moderator, Alison Krentel. Dr. Krentel is an associate professor at the University of Ottawa and a senior scientist at Briere Research Institute. She's also a senior research fellow at the WHO Collaborating Center for Knowledge, Translation, and Technology Assessment for Health Equity, and the current chair of the Canadian Network for Neglected Tropical Diseases. I would like to invite our esteemed panelists to join us. Representatives from Peru, Colombia, Mexico, and Guyana, please, from Ministers of Health. Thank you very much. The floor is yours.
Thank you very much, Judith. And welcome to our panelists. Thank you. So you have a translation there in front of you. Wonderful. Thank you very much, Judith, for the introduction. And thank you to PAHO for the kind invitation to moderate this session today. I'm honored to welcome us all to the panel on innovations and practical strategies for eliminating communicable diseases in the Americas. The Elimination Initiative, as we've just heard, which is led by PAHO and supported by countries in the region, takes a transformative approach by focusing on integrated health services for multiple conditions rather than by individual diseases. It enhances national and local capacities, adapts responses to community needs, and involves various stakeholders. And we'll hear from some of our partners today as well. Additionally, it addresses the social determinants of health and improves governance, stewardship, and financing through a people-centered approach. As a Canadian partner and researcher, I support the elimination of some of the neglected infectious diseases in the region of the Americas. And I have found that this integrative approach outlined in the Elimination Initiative provides greater opportunities to reach the women and men and the boys and girls most affected by these communicable diseases. By breaking down the silos of a single disease approach, we can improve efforts to better achieve health outcomes and health equity. As we will hear from our esteemed panelists today, locally driven innovations and approaches provide the pathway to success. And they also serve as examples to other countries in the region and also globally. They demonstrate the importance of good science and research and technology with the political commitment that is needed to achieve and accelerate towards the elimination goals. So we're honored today to have this distinguished panel, delegates from Mexico, Peru, Colombia, and Guyana, who will be sharing their experiences with us and best practices on innovative strategies that they have used to accelerate the elimination of diseases targeted by the Elimination Initiative. So it's my pleasure to introduce our distinguished panelists, Dr. Altez de la Torre Rosas, who is the director of the National Center for Prevention and Control of HIV/AIDS in Mexico, CENSIDA. Dr. Eric Peña Sanchez, the Vice Minister of Public Health of the Ministry of Health of Peru. Dr. Jaime Orrego, the Vice Minister of Public Health of the Ministry of Health and Social Protection of Colombia, and Dr. Frank Anthony, Minister of Health of Guyana. So welcome to you all. So we'll start with the first question for Dr. Altez de la Torre Rosas. In the past 5 years, Mexico has strived on the path to eliminate hepatitis C, bridging gaps and advancing solutions. So Dr. de la Torre, what innovative actions has Mexico implemented to eliminate hepatitis C, and what are some of the concrete results?
I'm changing to Spanish. Muchas gracias y bueno, para mí es un gusto estar entre colegas, amigos de toda la región y en especial el poder compartir en estos minutos un poco de lo que hemos hecho en México en estos años, que además no dejo de resaltar que el programa se inició justo en pandemia y entonces nos habla de una visión de sistemas resilientes. La primera parte es que en México tomamos un cambio en la perspectiva, una perspectiva de salud pública, de atención de ciertas personas con una condición a una visión de eliminación, con el compromiso de llegar a los objetivos del desarrollo sustentable y poder entonces tener también un sistema que sea centrado en las personas y en las comunidades y lo primero también en un uso optimizado de los recursos, específicamente con una negociación tipo Netflix para asegurar que toda persona pudiese tener acceso a ese tratamiento. Y entonces este programa encontramos 4 pilares específicos. El primero, un acceso universal y gratuito a pruebas y tratamiento con drogas de acción directa para hepatitis C para todas las personas que estén en el territorio nacional y que lo requieran. Esto incluye a nuestros hermanos migrantes, integración interinstitucional de acciones y de información, un enfoque de salud, de atención primaria a la salud y estrategias focalizadas en poblaciones más afectadas e investigación. Y si nosotros lo queremos dividir, fueron 10 pasos estratégicos. La primera es conocer y usar la información con un análisis territorial, pero un análisis de sindemias. Es decir, no el clásico análisis de esto es lo que sucede para hepatitis C, pero entender que también teníamos que integrar la información para tuberculosis, salud mental y otros determinantes sociales y así conocer cómo cerrar esas brechas. El segundo punto fue hacer estas acciones y un programa con y desde las comunidades, con una integración de un observatorio que al inicio nos reuníamos cada 15 días y esto incluye a todas las instituciones de salud, líderes institucionales, expertos en academia, salud pública, en atención, pero también líderes comunitarios, que durante todo este tiempo nos han ayudado a planear, implementar y vigilar la estrategia. El tercero, la simplificación y la generación de guías de atención que fueran transversales, que incluyera para la atención de hepatitis C no solamente el uso de estos antivirales, pero también una sección de salud mental, reducción de riesgos, daños y uso de sustancias. Y un modelo de implementación y escalamiento en atención primaria a la salud. México teníamos menos de 60 unidades para la atención de hepatitis C en el 2019 y a la fecha tenemos cerca de 2,000 unidades, la mayoría en el primer nivel de atención. Cambiamos entonces el modelo de una unidad especializada hacia una unidad de atención primaria a la salud con telementoría, entre otras acciones, y que esto al final esté disponible para la población. Al ser una condición nueva de esta visión, se ha tenido que capacitar tanto el personal de salud como a la población en general, y esto hemos hecho toda una serie de cursos en línea, telementorías, que ha sido fundamental. Tenemos más de 70 líderes, tanto en hepatología, enfermedades infecciosas, pero también en ginecología, salud mental y otra serie de acciones integradas que les ayudan a estas médicas y médicos generales en el primer nivel de atención a acercarles la información de las personas especialistas. Una parte fundamental, y es el sexto punto, es la información estandarizada centrada en la persona. Se desarrolló desde el principio del programa una estrategia que es nominal y que nos permite ver todas las acciones que se le realizan a las personas y que sigue a la persona durante el ciclo completo de atención. Independientemente de si cambia de proveedor en salud, esta información está disponible y que facilita también el uso de inteligencia y otra serie de elementos, y que está también estos visores disponibles para los tomadores de decisiones a nivel local, estatal y federal, así como una línea de acciones. El séptimo punto fue tener claridad de cuáles eran las poblaciones y los objetivos a alcanzar. Para empezar, decidimos a la población que vivía con VIH, considerando que teníamos acciones integradas y por lo tanto asegurar que los recursos humanos eran también dirigidos y disponibles, pero nos fuimos subiendo a personas privadas de su libertad, personas que usan sustancias, personas con enfermedades hematológicas, población migrantes, personas en centros nacionales de transfusión sanguínea, y después lograr también ya ahora la identificación de estos municipios prioritarios hacia la población en general. Esto nos ha permitido alcanzar la microeliminación de hepatitis C en las personas que viven con VIH en el país, pero también alcanzar cada año a más de el 70% ya de las personas que viven en privadas de su libertad o preparándose para su libertad, y también en lograr tener estos elementos de estrategias para poblaciones indígenas, poblaciones migrantes y los 56 municipios con la tasa mayor de acción. Una verificación territorial. Si uno implementa algo y no lo verifica, difícilmente vamos a tener resultados que sean sostenibles. Se ha hecho un comando de todas las instituciones que acuden y verifican estas acciones, y un análisis de brecha, que es el punto 9 y casi final, donde nos permite tener y saber dónde están todavía estas áreas de oportunidad, una visión de mejora continua, y agradecemos a la OPS porque nos ayudó también con el modelo económico y saber cuál es este impacto que ha tenido o esta estrategia podría tener. Y finalmente, la innovación en redes de laboratorios públicos, pero también privados, reconociendo que las personas pueden acudir a otras unidades y cada unidad, cada encuentro es una forma de alcanzar a la población. Esto nos ha llevado a la reducción ya identificada inclusive de trasplantes. Ya hepatitis C en México no es la primera causa de trasplantes y de mortalidad.
Thank you very much. Muchas gracias. And I think that the approach that Mexico has taken certainly has also paved the way for sustainability of these initiatives moving forward, in the way that you've demonstrated a flexible approach and the integration with primary health care. Thank you very much for sharing your insights with us. I'd like to address our next question to Dr. Eric Peña, please. Thank you. Peru is transforming the elimination of tuberculosis by using innovative solutions. So I'd like to ask you, why did Peru decide to use portable X-rays and artificial intelligence technology to eliminate tuberculosis? And what are some of the concrete results that you have seen? The floor is yours.
Thank you. Sí, muchas gracias por la pregunta. Muchos de nuestros países enfrentan situaciones de recuperación de la desaceleración del crecimiento económico que han sufrido tras la pandemia y algunos eventos macroeconómicos en nuestros países. Por lo tanto, nos resulta crítico hacer un uso eficiente de los recursos y también apelar a tecnologías que tengan esa capacidad disruptiva de poder ser muy eficientes para poder lidiar con problemas sanitarios como la tuberculosis. Perú, lamentablemente, tiene una de las más grandes cargas de tuberculosis y también de tuberculosis multidrogoresistente en la región. Y es precisamente en atención a esta necesidad que el gobierno peruano y el Ministerio de Salud decidió echar mano de estas tecnologías y de todo un equipo y una estrategia integrada para poder apuntar la lucha de estas enfermedades con una perspectiva de eliminación, como se está desarrollando en este panel. Relacionado al tema de la radiografía asistida por inteligencia artificial, existe un importantísimo cuerpo de evidencia científica que nos permite tener una buena certidumbre de la utilidad de esta tecnología. Sabemos de que utilizar radiografía digital ofrece una cantidad importantísima de ventajas y sobre todo asistida por inteligencia artificial en el sentido que, por ejemplo, reduce la variabilidad intra e interobservador. Reduce, por ejemplo, el tiempo del diagnóstico, permite la flexibilidad de utilizar este equipo en varios entornos. No necesitas una locación de un equipo fijo, lo que también reduce la accesibilidad en el contexto de poblaciones dispersas. Entonces, estamos hablando de una tecnología que, bajo diferentes perspectivas, constituye una muy importante ventaja en el tema del proceso de cribado e identificación de casos de tuberculosis. Nosotros, en esa perspectiva, no solamente hemos apuntado a implementar esta tecnología en la atención primaria, que es la columna vertebral de la atención en salud en nuestros países, sino el hecho de también aproximarla en contextos en donde existen poblaciones con alta prevalencia, la población privada de la libertad en el contexto de establecimientos penitenciarios, acercarlos más a la comunidad. Perú tiene, además de diferentes regiones con características geográficas muy diversas, población dispersa que es muy difícil de acceder en el contexto de las poblaciones indígenas, en donde lamentablemente la única vía para poder alcanzarlas es a través pluvial y muchas veces existen fenómenos climáticos que nos prohíben o no nos permiten accederlas. Entonces, tener acceso a estas tecnologías que nos permiten alcanzar estas poblaciones con la facilidad de tener diagnósticos muy rápidos, con los cuales se establece un algoritmo, un protocolo que permita tener una lógica de atención que nos permita diagnosticar de manera rápida, constituye una importantísima ventaja. En función de esto, nosotros hemos utilizado, estamos implementando estas tecnologías. Además, no solamente estamos avanzando, gracias a la inteligencia artificial y la radiografía digital, a diagnósticos más rápidos y oportunos, sino también mejora la precisión de los mismos. Es un procedimiento automatizado, perfectamente implementable en el primer nivel de atención y obviamente estamos asegurándonos que en el proceso de implementación recojamos toda la información necesaria para cuantificar el impacto que esto tiene sobre la reducción de la carga de la enfermedad y además de eso, cuantificar también el retorno de la inversión, porque cuando nosotros vamos ante el Ministerio de Economía y Finanzas, generalmente tenemos que tener argumentos sólidos para continuar con el escalamiento de la intervención y la sostenibilidad del financiamiento de la misma. Entonces, con todos estos argumentos, yo considero de que este tipo de tecnologías que realmente representan un paso hacia adelante en la lucha contra la tuberculosis es algo que no debemos de dejar de mirar y debemos de implementar con mucho esfuerzo. Finalmente, entiendo yo que además de esto estamos tratando de ser todo lo exhaustivos posibles en términos de la implementación de la estrategia de control de la tuberculosis, en el sentido también de implementar las terapias acortadas para terapias multidrogresistentes, la búsqueda activa, que es crucial. Estamos ganando tiempo en el diagnóstico y por lo tanto cortamos cadena de transmisión y reducimos la carga de enfermedad. Eso es vital. Entonces, yo considero que esta es una de las tecnologías que debemos siempre tener en cuenta. Gracias.
Thank you very much, Dr. Peña. And I want to highlight, thank you for your insights. And again, it's wonderful to hear about the flexibility of these different approaches and the ways that technology can help to actually reach people who are the hardest to reach and those that are particularly in difficult and vulnerable circumstances. So thank you very much. The next question I'd like to address is to Dr. Jaime Jorigo from Colombia. Colombia is committed to accelerating efforts to eliminate HIV, and expanding pre-exposure prophylaxis, or PrEP, is key to achieving this target. So what has Colombia done to expand access to PrEP? And what is the impact of this innovative intervention on the elimination of HIV in Colombia? Thank you.
Bueno, muchas gracias. Siempre es una combinación de políticas. En primer lugar, la actualización de la política de salud sexual y reproductiva, las políticas de las poblaciones que tienen que ver con la población LGBTQ y más, la población migrante, digamos, de todos los sujetos que pueden, por sus prácticas, no por sus opciones, tener exposición a un mayor riesgo. Y, por supuesto, en la política de salud, un plan de choque para retomar, como columna vertebral, lo dijo el doctor Yarbas, la atención primaria, que en el caso de nuestro país debe tener una característica y es la búsqueda activa, la participación de la sociedad, en este caso de las poblaciones que en términos de pares, que conocen los contextos, que conocen las situaciones, se pueden y deben involucrar. En ese marco, y algo que mencionaba la colega de México, y es que no podemos hacer abordajes, hay que tener especialidad, pero la especialidad debe ser parte de una integralidad, porque si vamos detrás de un evento y no de un sujeto que tiene derechos, empezamos a trastocar también la iniciativa. En ese marco, la alternativa que tenemos de la PrEP y de la PEP vienen a complementar un esfuerzo en el cual también debemos reconocer el papel que ha tenido el Fondo Mundial, ONU-SIDA, OPS, ICAP, Aid for AIDS, la academia, en el caso colombiano, la sociedad civil, el mecanismo país y, por supuesto, el ministerio. En el 2021 se hizo un primer piloto para que llegó más o menos a unas 500 personas. Luego vino la pandemia, en el 2022 ya se pudo llegar a 1.600 y con un cambio de política pública que fue incluir el costo de la terapia dentro de la UPC, de la unidad de capitación, de manera universal a partir de las administradoras de planes de beneficios, se aumentó la posibilidad de que la estrategia pueda funcionar. Al mismo tiempo hay sistema de información, al mismo tiempo está toda la evolución de lo que es la guía práctica, luego el lineamiento técnico, el fortalecimiento de capacidades del personal, trabajar también el estigma y la resistencia que hay a veces frente a este tipo de prácticas. Y finalmente, este año pues ya se ha llegado a 6.500 personas, es decir, un incremento del 400% en el acceso. Confiamos entonces que en la combinación de todas las estrategias en el marco de políticas públicas que garanticen derechos, esto ya se pueda convertir en una práctica de acceso universal al terminar este año y en el 2025.
Thank you very much. And I think you answered one of my follow-on questions, which would have been, how will you expand access to PrEP? And I think you have answered that with the inclusion in universal health coverage. I appreciated this balance between specificity and comprehensiveness, and I think that what we've learned, certainly from our speakers thus far, is it's important to consider the local context and the conditions of people as these programs are being developed. So thank you very much, Dr. Rego. The experiences from Colombia highlight how access and outreach through the social security system can help to bring better access to PrEP. So I'd like to now direct my question to Dr. Frank Anthony from Guyana. Guyana is advancing towards the elimination of lymphatic filariasis, and I was there in May in Guyana around lymphatic filariasis, so nice to see you again. And on this path, the Ministry of Health is innovating and leveraging geostatistical methods for surveillance. So what is Guyana specifically doing with geostatistical methods for surveillance surveys for the elimination of lymphatic filariasis?
Well, thank you very much for having me on this panel. I want to thank PAHO and for bringing us together so that we can share our experience. First of all, I just want to say it's not only lymphatic filaria that we're looking at. But of the 30 diseases that PAHO has targeted, we are looking at least 5 in Guyana, which includes lymphatic filaria. We're looking at Chagas, we're looking at leishmaniasis, leprosy, and we want to look at helminthes as well. And we feel that we're very confident that before 2030, that we'll be able to achieve elimination. In terms of lymphatic filaria, this has been a struggle that we've had with this particular disease for many years. And in 2021, of the 10 regions in Guyana, we have been able to use mass drug administration. And we were trying to make sure that microfilaria circulating in the population is less than 1%. And in 2021, when we did mass drug administration, of the 10 regions, we were able to accomplish this in 8 of the 10 regions. And when we look at the 2 remaining regions, which is the most populated regions in Guyana, regions 3 and 4, we felt that we probably need to go back and do mass drug administration in these 2 regions so that we can be very confident that we are eliminating the disease from Guyana. And so earlier this year, with the assistance of both PAHO and a technical team from US CDC and other partners, we have been able to go back to these 2 regions, and we conducted mass drug administration. And I think the target that we set ourselves of getting more than 65% of coverage, that we've been able to achieve that in both regions. So following this, what we'll be doing now is taking samples of the population to check and to make sure that we have achieved the prevalence that we're looking for. And so that's how we're using the geostatistical method to check to see how we have done. We'll be doing these types of surveys over the next couple of years until 2028. And once we maintain that threshold that we're looking for, then by 2028 to 2030, we'll be preparing our dossier to make sure that we can accomplish elimination. So that's our little story.
It's a great story. And I wonder if you could just add a little bit on some of the benefits that you've seen in using these methods, maybe technical or logistical or economic benefits that you've seen to using some of these new methods.
Well, certainly. I think for us, you know, it has been a burden for many of our patients because patients with lymphatic filariae, you know, they would have had all kinds of disfiguration. There's lots of stigma that is attached. People can't get jobs because of the way that the disease would have affected them. So I think this is changing that dynamic. We have seen a reduction in patients with these types of disfiguration, and I think that's quite helpful. So that's one component of it. But in terms of the economic benefit, we strongly believe that if we are able to achieve elimination of some of these diseases, then we can divert the resources that we save from this to other areas. I think the big challenge that we have now is looking at chronic non-communicable diseases. So if we can save on the infection side and divert these resources to other challenges, then that would help the country significantly. So that's what we're working on. You know, we always have this double burden of trying to allocate resources for both infectious and non-infectious diseases. So I feel if we can save on one, then we can put to the others so that we can be more effective at what we are doing.
Thank you. And thanks to Guyana for sharing your experience, Dr. Anthony. This is a new innovation, and Guyana is actually one of the first countries in the world actually who was using geostatistical methods in lymphatic filariasis. So a lot of countries have been watching this experience. So we just have a little bit of time left in our panel. So I wonder if I could ask each of you just to comment very briefly on how you're going to use this innovation that you described today to accelerate action in your country. So I'll ask the same question to everyone and just ask you to just briefly talk about how you see acceleration of the innovation. We can start perhaps here, Dr. Altez.
Las damas primero.
Yes.
Sin duda alguna, esta innovación nos debe de llevar a la creación de un sistema resiliente y capaz de responder a multiamenazas. Cuando tenemos un problema de salud pública, no podemos darnos la oportunidad de que éste se pare cuando un evento adicional llega. Esta capacidad de tener una visión de atención primaria a la salud, redes integradas de servicios, información que sea útil, pero sobre todo optimización de los recursos, tanto económicos como los recursos humanos, tiene forzosamente que llevarnos hacia el camino para la eliminación a través de sistemas resilientes y cambiar la visión para alcanzar y comprometernos realmente como lo estamos para alcanzar estos objetivos del desarrollo sostenible, porque de otra forma es imposible. No, el poder demostrar que invirtiendo en salud eficientemente no solamente se ahorra, por ejemplo, actualmente ya alcanzamos este nivel en la negociación donde cada paciente adicional ya no nos cuesta al gobierno, es decir, vengan y hay que tratar ahora a todas las personas que encontremos, pero asegurar que estos modelos con una visión de salud basada en valor lleva hacia la innovación a otras áreas.
Sí, muchas gracias. Yo considero que en el caso de la tuberculosis para el Perú, nosotros tenemos la perspectiva de que tenga la forma de intervención una perspectiva integral, ¿no? Lo dije en su momento, no solamente es la radiografía digital asistida con inteligencia artificial, sino también la implementación de las nuevas tecnologías para el manejo, tratamientos acortados de vía oral que mejoran la adherencia al tratamiento, la implementación de búsqueda activa y en general el enfoque bajo la perspectiva de la atención primaria es uno de los temas que nos permite a nosotros tener un abordaje integral, pero además la articulación intergubernamental, o sea, del nivel nacional, subnacional y nivel local es crucial. El compromiso con las autoridades, el manejo de los determinantes sociales, esta perspectiva de enfoque integrado, multidimensional, es la perspectiva que nos va a permitir hacer la eliminación. Y como también lo mencionaba hacia el final de mi intervención, la única manera de garantizar la escalabilidad y sostenibilidad de las intervenciones que nos permitan no perder el momentum inicial de éxito en la implementación, sino hasta el escalamiento total en todo el territorio nacional y por consiguiente la eliminación de las enfermedades, requiere también de un importante análisis de economía en salud. Tener argumentos técnicos para garantizar que tengamos la evidencia del impacto que tiene, no solamente en la salud, sino en la economía del país, genera una, digamos, garantía de que vamos a contar con los recursos para mantener estas intervenciones y lograr el éxito que realmente se busca en la lucha de estas, ¿no?
El estricto orden. Bueno, sí, ya en efecto lo habíamos planteado, pero la sostenibilidad está asociada, en el caso nuestro, definitivamente a que podamos transitar en una reforma en la cual el aseguramiento de mercado pase a un aseguramiento social. Porque lo que nos sucede, y esto quiero compartir la experiencia, es que financiamos la PrEP universal, pero el asegurador no hace la gestión del riesgo, no hace la búsqueda activa, se queda con los recursos y eso nos desfinancia. Entonces, por eso está transitando una reforma en el Congreso, pero al mismo tiempo hemos desplegado un plan es uno de los 3 países con Plan Nacional de Control y Eliminación, ahí está obviamente VIH, porque creemos que hay que salir de la inercia, de la normalización, de que hay como este año no lo logramos, este año no, hay que lograrlo, es decir, es un tema también de voluntad política. El tercero es la participación, pero una participación que debe ser, en el mejor de los términos, es una participación política de la sociedad para garantizar sus derechos. Digamos que aquí la innovación es más de tipo social y de política pública que de un recurso como tal, porque ya existía. Lo que hicimos fue poderlo, más cuando en un primer estudio que se hizo en el 2020, de 590 personas que utilizaron la PrEP, ninguna en un plazo de un año se había, digamos, infectado. También tiene que ver la sostenibilidad financiera de todo este tipo de tecnologías. Y aquí hemos dado un paso en relación con el dolutegravir, pues que no hace parte de lo que estamos hablando, pero es un ejercicio de soberanía sanitaria. La licencia obligatoria para dolutegravir como medicamento de primera línea, tuvimos el apoyo también de la OPS, de ONUCIDA, de la comunidad internacional, porque creemos que no tenemos por qué pagar precios injustos por medicamentos que se pueden adquirir, digamos, a un valor. Y estamos trabajando en recuperación de capacidades en investigación y producción en Colombia.
I think for us, the innovation here is its adaptability to other diseases. So using these using these methods, I think we can see that rather than trying to do it for the whole population, that we can select groups of people and then we can get the prevalence, and so we know whether or not we are responding appropriately to the disease. So I think this is, we are demonstrating this with lymphatic filaria, and I think it's going to be applicable to other diseases. And if we can do it in Guyana, I think other countries who are looking at eliminating other diseases in the region can adopt these techniques and use them for your own country. So I think that's where the innovation is leading, and we hope that we can share our experience with you. We have a very good technical team that is working with us. So apart from the local people at home, the local people in Guyana, we have a strong technical team from PAHO and our partners in Canada and US CDC that has been working with us. So that I think the universality of these principles are what is important. And so other people, when you adopt it, you can rely on the sound technical principles that lie behind it. So we are only demonstrating it. So I think that's the key here. So we are willing to be part of this sharing and experience that we have. We want to share that with the rest of the countries. Thank you.
Thank you very much. And as I sit here as a researcher, I think, it's very difficult to come up with new ideas and research, but actually, I think the challenge is in the scalability and sustainability. And I think each of you have really given us a wonderful example of how a new technology has shown so many promising results and how it can be scaled up to accelerate the elimination efforts. So I hope that the insights that have been shared today will inspire other countries and partners in the region to accelerate your efforts to eliminate communicable diseases. So I'd like to thank our panelists and invite you all to join me in a round of applause as they return to their seats.
Thank you. We're now going to start the second panel. I invite a distinguished group of partners from United, Global Fund, USAID, and Canada to join us, to join Alison and the members of this panel. As we change in chairs, I just want to reflect as a director of an Innovation and Access to Medicines Department of PAHO, I think we heard very clearly today that technologies are only useful if they serve a public health and equity vision that the representatives from 4 governments of the region have shown us today. It's not only about introducing tools, it's about innovating how we use these tools and ensuring they reach the population and the health systems that we're all serving. So really an honor to work with you. We also heard that there are structural challenges on R&D, on manufacturing, on affordability, on the centralization of services. So the role of partners and communities and civil society is essential here to ensure that the ministers of health and the organization have not only the resources we need, but they need, but also that we all work together on the structural challenges around innovation and access to health technologies so we can serve that public health and equity vision that was presented today. So thank you. The floor is yours.
Very much, Judith, and welcome to our next panel. So the elimination agenda, as we've heard, is a comprehensive framework aimed to eliminate a broad range of diseases, including vaccine-preventable, neglected infectious, zoonotic, vector-borne diseases, as well as cervical cancer, tuberculosis, sexually transmitted infections, and conditions related to mother-to-child transmission and environmental risks. So achieving the initiative's targets requires a concerted effort from countries, partners, stakeholders, and communities. Developing and implementing innovative solutions is crucial for disease prevention, case management, and alleviating suffering, especially for those populations who are living in vulnerable circumstances. And this will ensure that current and future generations can be free from these communicable diseases. So we're now honored to hear key perspectives from partners and civil society organizations on PAHO's initiative to eliminate over 30 communicable diseases by 2030 and their role in reaching these elimination and ambitious targets. So please join me in welcoming Massimo Guidanelli, a member of the board of the Global Fund, for his insights. So welcome, Massimo. The floor is yours.
Well, interchangeability. Thank you very much, and good afternoon, everybody. Let me start by saying that the Global Fund is currently the largest multilateral financial global health initiative addressing HIV, TB, and malaria, as it distributes over $5 billion a year to eligible countries in financial and technical assistance. Over the years, the Global Fund has also grown into the largest supporter of what we call RSSH, Resilient, Strengthened Systems for Health, especially following the experience of the COVID-19 pandemic. Now, there's already well established, it's not a new story, the Global Fund has been there for more than 20 years, and there's therefore a very well-established partnership with PAHO on a number of issues. But if we take a close look at both the Global Fund operations vis-à-vis the Elimination Initiative, we definitely come up and identify amazing matches, commonalities and common grounds, ongoing synergies, and perhaps potential for further expanding this ongoing partnership. 3 points stand out for clarity. One is both Global Fund and the Elimination Initiative do share and pursue elimination goals. They are firmly committed. The Global Fund through a mandate which is specific to HIV, TB, and malaria compared to the broader scope of work of the Elimination Initiative and its 30+ candidates to elimination. However, they both fit into the perspectives and the ambitions of the Sustainable Development Goal number 3 by 2030. Second point is that both Global Fund and the EI firmly rely on principles of health equity, protection of human rights, gender and diversity rights, and as such, I would say inevitably, the focus of their action is on vulnerabilities, particularly on key and vulnerable populations that are disproportionately affected by the 3 epidemics or by many other communicable diseases. The third point is that both Global Fund and EI put a major accent on the importance of strengthened, sustainable, resilient health and community systems, the need to integrate services, hopefully through a primary healthcare approach, and having a person-centered approach, and inevitably again the active participation and involvement of affected communities. I would say also, in addition to that, that against the recent experience of the pandemic, there's a recognition of the urgency of preparing health systems more adequately to pick up health challenges, including future epidemics, pandemics. In fact, the Global Fund is already supporting extensively the region in what concerns those 3 diseases by providing the 24 eligible countries with financial and programmatic assistance in the range of 350 to 400 million per grant cycle, which is over 3 years period. Let me stress how most of those resources, or at least a significant proportion of those resources, has gradually migrated to be specifically allocated on activities related to key and vulnerable populations, and over the last few years, increasingly on strengthening resilient health systems. I think there's inevitably, and this is my perspective, there's definitely ample room for, going back to all those commonalities, there is ample room for further expanding the synergies and partnership with PAHO, particularly in leveraging the Global Fund already significant investment on HIV, TB, and malaria towards strengthening resilient health systems and community capacity. And I think together there's a possibility to achieve significant degrees of efficiencies, sustainability, and innovation, words that have become very prominent here. Just an immediate suggestion could be to unpack these concepts of commonalities and maybe develop communication and guidance tools that could in turn inform the development of the forthcoming rounds of development of grant proposals. Let me conclude by thanking PAHO, Dr. Barbosa and Dr. Seeley for the opportunity to share these remarks, but also to congratulate the health ministers and ministries of health for their significant achievements. Thank you very much.
Thank you very much, Massimo, for sharing those insights from the Global Fund. Next, I'd like to turn to Robert Matiro, who is the Director of Program at UNITAID, to give us his insights. Welcome, Robert. The floor is yours.
Thank you. Thank you very much to PAHO for inviting UNITAID to be on this panel. So UNITAID, as a global multilateral that focuses principally on health innovation and accelerating access to health innovation for low and middle income countries, what I want to do is just share some concrete examples that illustrate just how crucial innovation and best practices are to this really inspirational elimination initiative agenda that PAHO has set forward. And I'll focus on three things, how UNITAID sees it when we talk about innovation. And those three things are about optimization, simplification, and acceleration. And if you talk about optimization, it means that if we're going to hit these elimination targets across that many diseases and health conditions, we have to get progressively more effective in deploying the tools, the health products, as well as the approaches that are going to bring us there. And some couple of examples from the recent historical past will show that this is possible. And I'll give you the example of dolutegravir, which is now the leading first-line treatment for HIV. That product, when it was first approved by the US FDA in 2012-13, only 5 years later was introduced into low and middle income countries, starting in Africa. And that was a record. It usually takes 10 years. But this is a product with higher barrier to resistance, highly efficacious, bringing down viral load within a matter of days and weeks, and are much more forgiving for patients with fewer side effects, right? Therefore helping with adherence. But this is an example of continuous optimization in the HIV antiretroviral space that has brought us to have such a blockbuster product. But what was really crucial about that product is the efforts that multiple partners took around the world to ensure that from the time it was introduced in high-income countries, we could shorten that time significantly to the time it was reduced in low and middle-income countries. And for adults, that time was cut to a matter of 5 years instead of 10. And then also for children, it was also slashed from normally 10 years to just 5 years as well. So the pediatric formulations followed shortly thereafter. So it was a holistic approach to ensure that a game-changing technology came more quickly and could be scaled significantly. So the innovation side was key. But then part of, and you heard it earlier from one of the earlier panelists, you need to build into the so-called target access product profile of an innovation scalability. And that's why as the innovation came, it was so key to line up with national governments, with the Global Fund, with PEPFAR, with others, that scale funding so that that product could reach millions and not just a few thousand. That's optimization as an example. If I look at simplification, we're talking about, for example, two things, not exclusively, but two things. Decentralization of care, so taking care closer to where the people who need that care can access that care. And that means if you look at diagnostics, looking at better point-of-care technologies, rapid tests that can reach people, but also self-care. And in the last 5 years, a couple of examples of self-care that has been scaled massively, and again, I'll borrow from the HIV space, is HIV self-testing. 7 years ago, HIV self-tests were used by a few thousand people. Now it's into the millions, but it was a concerted effort end-to-end, UNITAID working with several other partners to position those tests for scalability, right? And with self-care, we can start to close that remaining gap of people who don't know their HIV status, who can get tested and then linked to care. And that's since expanded to other types of self-care, hepatitis C testing as well on the same tests. And now if you look at cervical cancer, self-sampling, if you look at vaccination for HPV, moving from dual dose to single dose, these are adaptations that are allowing simplification of care that can then get more people accessing that care. And then lastly, acceleration. And I think that is really key. And you heard it again from the previous panel, the ministers and vice ministers. There are ways of doing things differently now that can get us to those elimination targets more quickly. So we can't do things the way we have always done them and then expect different or more accelerated results. During COVID, we saw the difference of the approaches to the clinical trials that were taken to bring us vaccines in record time. But there's also adaptive clinical trials that we can do now. We've seen it with MDR-TB, right? With massive adaptive clinical trials in a much shorter time frame that are brought us shorter, less toxic regimens for that. And if you look at also product introduction, we need to move away from just piloting all over the place and doing enhanced rapid monitoring as we introduce new products into countries. So that is key. And I'll just close, because I've only got 3 minutes here, by saying two other things so that we don't oversimplify what innovation can bring. Political will, and you heard it from the previous panel, is absolutely key to enable this, and also financing. Thank you.
Thank you very much. Thank you, Robert. I'd now like to invite Emily Wainwright, who is the Senior Neglected Tropical Diseases Advisor for Strategy and Partner Engagement at USAID, to share her insights. Welcome, Emily.
Great, thank you. And I just, as everyone else was saying, I just really want to thank PAHO for the opportunity to be on this panel and talk about the Elimination Initiative, and just I see the opportunity to actually bring a more kind of operational look at how do we tackle with this intersect that exists between disease program acceleration and also the reality of trying to use and optimize systems and resources in country. I think the panel before was very clear. We've got to be able to use those resources most effectively. At USAID, like many in the neglected tropical disease community, we spend a lot of time and energy focusing on the prevention aspects of 5 diseases. That parallel strategy has made a lot of progress, but I think the limitations of that are really presenting themselves, because for most of those diseases, the investment to ensure treatment for those who are infected has not received the same level of attention that the prevention programs have. And as a result of that, we've also seen there are these other 15 diseases out there that have not benefited from that kind of momentum and have been lagging behind. So, and in the current environment, I'm going to gather there's very little appetite for 15 big parallel new disease programs out there. That's just not the world we live in anymore. And that, you know, how do we rethink the use of strategies to tackle NTDs? And I think this is this opportunity that the primary healthcare investment, strengthening those cross-cutting systems, is that glide path for bringing in the new diseases. But I think it's not just ensuring that you can tackle those diseases. In the previous panel, and I will call out Guyana for this, I think it's a really nice example to show it's both sides, right? We strengthen the system to deal with multiple diseases, but any individual disease still has to meet its target, and the innovations that they are grappling with can be brought in and benefit other areas and other disease programs. So I think it's always that challenge, right? How do we think about what we're strengthening and how it brings together? Because the realities that governments are talking about when we talk about getting to vulnerable populations, meeting them where they are with as many services that meet those functions, you know, that's a growing challenge. And the 2 take-homes for me, I'm going today out of the previous session, is we have to be able to not only use innovation, but we need to be flexible with innovation and really breaking this paradigm of everything is one size fits all. I understand that that's efficient, but that's not meeting your populations where they are. And so I think this kind of helps to facilitate that cross discussion of what can we learn and how can we deal with that. For me, in the universe I live on a day-to-day basis, I think that's particularly important for neglected tropical diseases because they're behind and they're not on track to meet the 2030 targets. They are not on track to meet the Sustainability Development Goals, and this kind of a strategy actually opens up a pathway for those other diseases to hopefully get back on track and catch up, as well as being working in a context where systems are ready to bring in the new tools and strategies that are going to be required. So thank you.
Thank you, Emily. It's now my pleasure to give the floor to His Excellency Stuart Savage, Ambassador, Permanent Representative of Canada to the Organization of American States, to give us his insights. So welcome, Ambassador Savage.
Merci beaucoup. Il me fait grand plaisir de vraiment d'être avec vous aujourd'hui et parler de ce sujet si important, l'initiative pour l'élimination des maladies contagieuses. Je vais partager avec vous certaines de nos contributions à l'OPS en ce qui concerne cette grande initiative où le Canada a choisi de mettre une emphase sur le trachoma. Mais cet engagement du Canada ici à l'OPS et spécifiquement avec cette initiative pour l'élimination des maladies contagieuses est vraiment ancré dans la croyance du Canada que tout le monde devrait vivre sans maladie ou bien dans un état de santé où il y a des maladies prévenibles. Alors, la raison pour laquelle le Canada a signé cet accord de travail avec l'OPS, entre autres, et le Canada continue de promouvoir l'inclusion des maladies tropicales et de leur traitement dans l'offre des soins de santé de base partout où on travaille. So specifically with PAHO, excuse me as I juggle, Canada is working on trachoma here in Latin America. And trachoma, as many know, is a leading cause of blindness in the world, not just in the region. And there's a causative relationship between trachoma and poverty that is bidirectional in the sense that poor households tend to be more affected by trachoma, and trachoma infections reduce productivity of households and families, and women in particular, which keeps them in that poverty trap. The disease is endemic in many rural and remote areas and affects some 5.5 million or more people in the Americas. Canada's work with PAHO supports expanded technical cooperation in 10 member states, and we hope together to reach about 10 million people across the hemisphere. The project specifically is entitled Improve the Health of Communities, Women and Children by Eliminating Trachoma as a Public Health Problem in the Americas. And we are working specifically in Guatemala, Brazil, Colombia, Peru, Venezuela, Bolivia, Ecuador, El Salvador, Haiti, and Mexico. And it's the use and the technique, I think, which is probably most relevant for the discussion today, is to advance an evidence-based strategy called SAFE. SAFE is an acronym which stands for the use of surgery, for S in the SAFE, to prevent visual impairment and blindness, antibiotics to reduce infection, facial cleanliness to prevent infections, and working on the environmental improvements to reduce transmission of trachoma. These 4 components are essential in treating and preventing the spread of this disease. It's a holistic approach, and it addresses some of the root causes, and it is integrated into healthcare actions across this programming. The elimination of trachoma is, I think, a proof of Canada's interest in going beyond simply dealing with disease, but also getting at causes of poverty and underdevelopment, and hopes that we can contribute through this to doing more than simply helping individuals, which is extremely important, but also helping them and their communities develop. So thank you.
Thank you very much, Ambassador Savage. And now we will see a video pre-recorded with the intervention of Dina Choc, who's a health promoter of the Kichi Mayan indigenous community in Guatemala, and she's going to share her reflections as an important partner, community partner in the elimination agenda. So I think it's just behind us. Yes, please go ahead.
Ukushkaj, ukushulev, kamaltakbe, maltiosh, chechle, espacio shiachekech. In junali, maya kiche, kapetik pale komon reche huyup, rech zoología lekaishimulev, Guatemala. Los líderes comunitarios son importantes para la apertura de mejorar los servicios de salud, ya que el acceso a la comunidad fluye más con el apoyo de ellos, porque la población, la comunidad confía en ellos. También es importante escuchar las demandas y necesidades desde las comunidades. Es necesario tener un diálogo como servicios de salud, así como las demandas reales desde las comunidades, cómo perciben desde nuestra cultura, cómo podemos eliminar las enfermedades. Entonces es importante generar diálogo para poder escuchar las demandas reales. Existen leyes que amparan el acceso a la salud, pero necesitamos fortalecer planes de acción para poder llegar a las comunidades más lejanas, sumando esfuerzos, promoviendo los recursos necesarios para la eliminación de las enfermedades transmisibles. Un saludo cordial para todos, un abrazo para cada uno de ustedes. Maltiosh.
Excellent. So I'd like to thank all of our partners that are here today for sharing your insights and your commitment to supporting the Elimination Initiative in the Americas. You've emphasized the importance of collaborative efforts, efficient resource use, and cross-cutting strategies that are crucial to achieve our goals and reach those in the most vulnerable circumstances. It's been an honor for me to be part of this session. I'm delighted to be here today and also to learn about the impactful work that's happening in the region to improve lives. So before I turn the floor back to Judith, I'd like to ask you all to join me in a round of applause for our panelists.
Thank you for this excellent panel. Now it's my deep honor to invite Dr. Sylvain Adihiri, Director of Communicable Diseases Prevention, Control, and Elimination Department at PAHO. The Elimination Initiative is everybody's business at PAHO, but I will say it has a father and a mother. You are the father, and of course, Marta Savoia is the mother. We all follow
You're the godmother.
I am the godmother. We all follow your leads, both of your team and your lead, on pursuing these objectives. Thank you.
Thank you, Judith. It's always challenging because we are already a little bit late. It's a very complex day. Thank you, ministers, excellencies, partners, colleagues. A couple of highlights of the last sessions and some personal considerations. We have listened about innovative interventions. I think it's a key aspect in Guyana, Mexico, Colombia, and we have listened a lot about the importance of organization of health services, including strengthening of primary health care, access to communities, including key populations, and resilient health services. Many of you mentioned resiliency, and access to technologies, including vaccines, tests, and medications. It will be a nightmare for the translator now. Une touche un peu plus personnelle, qui est importante de mentionner dans le cadre de l'initiative d'élimination, c'est la coopération entre les pays, entre pays frontaliers et entre pays de la même sous-région. L'élimination ou la certification de l'élimination ne peut être possible souvent qu'avec une coopération étroite entre les pays. Je pense à la bilharziose dans la Caraïbe orientale. Je pense au paludisme et à la filariose lymphatique sur l'île d'Hispaniola, par exemple. Y el tercer punto, otra vez un rompecabezas para nuestros colegas, es la importancia de los determinantes sociales. La aceleración de la iniciativa de eliminación depende de la capacidad de los servicios de llegar a las poblaciones vulnerables, muchos de ustedes lo mencionaron, incluyendo poblaciones claves, incluyendo comunidades indígenas, como lo mencionó la colega promotora de salud en Guatemala, las minorías afrodescendientes. Realmente tenemos un desafío a llegar hasta el nivel comunitario y para transmitir todo un paquete de intervenciones sostenibles. Agradezco mucho su participación. Ha sido un honor de recibir a todos ustedes en esa sala y que tengan un buen día ahora. Gracias.